All right, so this is the second part of some review questions for neurology. So question 7 is a continuation from question 6. If you haven't watched the first set of review questions, I suggest you do. So this was a stroke patient, and the head CT revealed a wedge-shaped area of hypodensity in the region of the left middle cerebral artery, which, if you saw the previous question, you should know that it was in the left middle cerebral artery range simply because of her symptoms. She had right hemiparesis and aphasia. No other abnormalities have been noted. It has now been 50 minutes since the onset of symptoms. Vitals are presently 150/100, heart rate is 95, temperature 97.4, respiration is 13. Assuming all necessary laboratories have been performed and no other significant medical history, which of the following would be the best next step in the management of this patient? A. Heparin. B. Cerebral angiogram. C. Alteplase. D. Admission to the stroke unit. Or E. Control of hypertension with an IV beta blocker. All right. Let you pause it here. And the answer is C. Alteplase. So this is a patient who has an ischemic stroke, as the majority of patients do. However, it's really important to know when it is appropriate and when it's not appropriate to give the tissue plasminogen activator, of which there's multiple. So tissue plasminogen activator is more of a just a category for lots of different drugs. We tend to use Alteplase or Retaplase. They're recombinant agents. They're easier to produce. They've got less side effects. Alteplase is usually, I think, a little bit more commonly used. But there's also streptokinase, which is used as well. What's really important here, though, is that you know that this is an ischemic stroke, and that with an ischemic stroke, what we want to do in all cases that we can is to use a clot buster. So how do we know this is an ischemic stroke? Well, she's got a head CT, which reveals a wedge-shaped area of hypodensity. Now, with a hemorrhagic stroke, we would see a hyperdensity because we would see fluid, we would see blood. With the hypodensity, we see necrotic tissue, we see ischemia. This is the big reason why I emphasize that we're getting a non-contrast CT, because if we were to get a contrast CT, then we would not be able to tell if it was ischemic or hemorrhagic. So what are the eligibility criteria for TPA? Now, there's a lot, but don't worry about the USMLE bombarding you with all of these. And a lot of these are relatively obvious. So if the patient has had, the ones to remember, if the patient has had a stroke or any kind of head trauma in the last 3 months, no TPA. If they've had an arterial puncture and a non-compressible site in the last 7 days, which is not common, then no TPA. And if they've got any kind of acute internal bleeding or trauma, then no TPA. The big one to remember, I mean, those ones are kind of obvious just because if you've got a big bleed, you can't, and also the past medical history of intracranial bleed, if you've got a big bleed or you've ever had a big brain bleed, you can't use something that's going to possibly break a clot, a necessary clot in the brain. The other ones are blood pressure, glucose, and coagulability. So your blood pressure, if it's too high, the problem is that if you give this clot buster, which could break up a necessary clot that's preventing a bleed, then you may actually cause a hemorrhage. So if your blood pressure is over 185, over 110, then you can't give TPA. If your platelets or coagulation are messed up, so if your platelets are less than 100 or your INR is greater than 1.7, no TPA. If you've got an elevated PTT, no TPA. If your glucose is less than 50, no TPA. However, what you can do is you can give the patient glucose and then ultimately give them TPA. Multilobar infarct is also an exclusion for TPA just because it's difficult to break all those clots at the same time. Now, for TPA, as far as the big contraindications, the big ones to remember are any past medical history of intracranial bleed, blood pressure greater than 185 over 110, and significant head trauma in the past 3 months. I would say if you have to memorize any three, I would remember those three. These ones, like the INR and the platelets and the PTT, they're kind of obvious because if you got 30,000 platelets, you're obviously not going to give something that's going to make it harder for you to form a clot, because it's hard to form a clot to begin with. But I know there's a lot of them. You definitely have to remember them for real life, but for the USMLE, just kind of remember them categorically, I guess is the best thing I can say. But this goes back to why it's so important to make sure that you're getting the patient's glucose level, you're getting their coagulation profile, and you're controlling their blood pressure. Now, if the patient's eligible for TPA, you should administer it as soon as possible, obviously. The sooner the better. Within an hour to 90 minutes is the goal. But like I said, the sooner the better. 3 hours has been set as the window, and it's really not because it's necessarily dangerous to administer it after that, but because we don't really see a whole lot. We don't see a big improvement in the results if it's administered after 3 hours. However, I think I've seen something in the literature that said that now you can administer it up to 4 hours after the symptoms. Okay, question 8. A 32-year-old woman presents to your clinic complaining of difficulty walking. She says that over the past few months, she's had frequent trips and falls, which are embarrassing to her because she says she's tripping over her own feet. She has had this problem since last year, but didn't see a doctor because it went away on its own. Physical exam is notable for weakness at the left ankle, but is otherwise unremarkable. Her current medications include levonorgestrel and naproxen for frequent headaches. On that note, she asks if she can be checked for glasses as she has had trouble with her vision lately. Which of the following is the best next step in the management of this patient? Is it A, lumbar puncture, B, brain MRI, C, discontinue levonorgestrel, D, head CT, or E, physical therapy? All right. And the answer is B, brain MRI. So this is a patient, although she is young, we do need to remember that young patients may have severe neurologic problems as well, and the most feared neurologic problem in young patients, especially with these problems that come and go, is multiple sclerosis. So remember, symptoms that come and go. What's another way to say that? Relapse and remit. And relapsing, remitting multiple sclerosis is the most common type of multiple sclerosis. So any patient that has focal neurologic symptoms that come and go, that is very, 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 very suspicious for multiple sclerosis, especially when it's weakness or even paralysis. Another thing that makes you think that this is possibly multiple sclerosis is that she's having ocular symptoms, and ocular symptoms are also very common in MS. So the best step when you are concerned for multiple sclerosis is an MRI of the brain. So in inquiring, many patients will have a past history of transient focal neurologic deficits, like these coming and going problems, and a lot of times because they come and then they go, they're not addressed, and so they remit spontaneously and the patient doesn't go in and see a physician. So they'll have a history of these things coming and going, and then finally they go in and see somebody. So a lot of times this isn't the first occurrence. It's also worth remembering that multiple sclerosis tends to present first in young, otherwise healthy adults. So this isn't something where you have risk factors. This isn't something where, like stroke, where it's like hypertension, hyperlipidemia, diabetes, and so forth. This can happen. This occurs in young people in the prime of their life that have no other health problems. And so it's a really unfortunate disease. The symptoms include weakness and paresthesias. Weakness, like we saw in this patient, they can be either focal or they might not correspond to a singular lesion. In this case, we did have a patient with a focal neurologic deficit. She had a weakness of the ankle. And it can also present as blurriness and diplopia, which we saw in this patient, which is why she asked for the glasses. She's probably been experiencing some optic deficits, blurriness, maybe a change in vision, diplopia, etc. So that's another thing to keep an eye on when you're looking for multiple sclerosis. And then optic neuritis is another thing that you can see, and that's pain with eye movement. And that often coincides with other ocular symptoms like blurriness and diplopia. So the blurriness, eye symptoms, weakness, focal neurologic deficits in a young person coming and going is usually multiple sclerosis. And when you have a clinical history and presentation that suggests MS, the best initial step is an MRI. So MS is a disease of what? It is a disease of the upper motor neurons, and it is a disease of myelination. So what you've got is demyelination of the upper motor neuron. So this is going to be an upper motor neuron disorder. And you can see this in some of the other symptoms that you have. You may have hyperreflexia. That we didn't see in this patient, but that's something that you might see. So this is an upper motor neuron disorder. So the places you're going to look for plaques or the lesions are going to be the spine and particularly the brain, because that's where the upper motor neurons are. This is an upper motor neuron disorder. And the MRI is required for diagnosis. Other tests that you may see, either probably not in the USMLE, but in real life, would be vitamin levels. A lot of patients with MS have low vitamin D, but certainly that's not a specific or sensitive test for MS. CSF analysis is often done, which would show an oligoclonal band. I would remember that for the USMLE, but that's not diagnostic either. And then a evoked response potential, which is delayed, can be suggestive of MS. So all these things are suggestive, but none of them are diagnostic, except for the MRI. The MRI is required for diagnosis. It's how we make the diagnosis. The CSF analysis showing that oligoclonal band, that's just proteins in the CSF. And those proteins are thought to be the actual antibody or the disease, the disease agent that's causing the demyelination. Okay, question 9. So brain MRI reveals multiple white matter plaques, so we know this is MS. Which of the following would be the most appropriate therapy for this patient at this time? A, azathioprine, B, mycophenolate, C, methylprednisolone, D, interferon beta 1, or E, glatiramer? Okay, the answer here is C, methylprednisolone. So there are 3 parts of treating multiple sclerosis. 1, we have to treat the acute exacerbations, these acute weaknesses that are affecting your daily life. So that would be what this patient has right now. 2, we have to treat the disease progression. So when the patient isn't having any acute exacerbations, we do need to have them on therapy to slow the progression, because this is a disease that's progressive and ultimately leads to really severe problems. So we want to slow the progression as much as we can, and that's done with this long-term therapy. And then thirdly, we treat any kind of complications, which aren't exacerbations from the MS, but they're complications from the MS, and we treat those symptomatically. So these are the 3 things that we do as far as treatment for MS. And in this case, the patient has an acute exacerbation, so we have to treat that first. And what do we do for treating acute exacerbation? We do steroids. And steroids are our best first step for treating anybody with MS that's symptomatic. And the way we do this is with an IV steroid first, and that's done for a couple days. Usually the patient's going to need admission. And then we follow that with a taper of oral steroids, which is done for between 3 and 4 weeks. And obviously, you know that you can't just give IV steroids and then just stop steroids, because that would cause some severe adrenal deficiency problems. So we taper steroids after we've treated them for a couple days. And usually within those first couple days, the patient does show a significant response, and so their symptoms tend to go away, if not remit. So this patient would need to be admitted, put on IV methylprednisolone, which is just the IV formulation of prednisone, and then she should show a response, and then after that she can be discharged on PO prednisone. But just remember that any patient with MS who's got acute symptoms, they're going to need to be treated immediately and with steroids. Now, steroids used to be how we treat MS for the whole disease. We don't need to do that anymore because we've got better drugs. But theoretically, you could treat MS with steroids the whole time. We don't do that because we've got better drugs and because steroids cause side effects. Okay, what do we do for the disease progression? Well, like I said, we used to use steroids. Now we give them this disease-modifying therapy, non-steroids, because it leads to less worse side effects than steroids. So there's still side effects, but they're not as bad. So the most commonly used drug for the long-term therapy for MS, so now we're talking about treating them forever, not just when they're having their flare-ups. The drug that we use is interferon beta. And interferon beta is known for causing flu-like symptoms, and that's simply because when you get the flu, when you're getting sick, your body is actually releasing interferon beta. So you're having your flu-like symptoms for a very understandable reason. So the most common agent is interferon beta. I would imagine that's going to be the one that is most likely to come up on the USMLE. Another one that is used quite often is glatiramer. And glatiramer is noted for its relative safety during pregnancy. So if this woman was, for instance, somebody who wanted to become pregnant, or let's say she came in and she asked, I want to get pregnant, can I switch to a different drug or something like that, then glatiramer would be the best drug. It would be preferable to interferon beta 1. Why? Because it's relatively safe during pregnancy. But, and I need to emphasize this, all agents are technically bad during pregnancy. None of these are good drugs during pregnancy. But glatiramer, out of all of these drugs for multiple sclerosis, is the least worse. So it's the most preferred drug during pregnancy if you have to take one. So glatiramer for pregnancy. Interferon beta 1 is another drug used, and then there's some newer drugs, but they're used for patients more so that aren't responding to interferon and glatiramer, and those include natalizumab and fingolimod. But like I said, they're not used as much because they have some more significant adverse effects. Natalizumab has an association with progressive multifocal leukoencephalopathy, which remember is caused by the JC virus. And fingolimod can worsen complications of diabetes mellitus, such as macular edema, and can cause some cardiomyopathic issues as well. So interferon beta 1 or glatiramer for treating the disease progression. Steroids for treating the acute exacerbations. And then the drugs that are used to treat some of the various symptoms. So remember, multiple sclerosis is an upper motor neuron disorder, so we can get muscle spasticity from multiple sclerosis just because it's an upper motor neuron disorder. What can we use? We can use muscle relaxants for that. Baclofen, dantrolene, or the benzodiazepine diazepam. Preferably diazepam if we're using it for at night. We don't like to give diazepam during the day. Why? Because like all benzodiazepines, it causes sedation. Fatigue and narcolepsy can come with multiple sclerosis. Also, just because it's affecting the brain. So for that, we treat it just like we would treat any narcolepsy. Amantadine, modafinil, methylphenidate are all fine. Pain can come with multiple sclerosis, so we're going to use some of the drugs we use for chronic pain. Phenytoin and carbamazepine, which are anti-epileptic drugs, and pregabalin. And then urinary urgency, this is another manifestation of multiple sclerosis being an upper motor neuron disorder. Because the upper motor neuron causes spasticity, you can have spasticity of the detrusor muscle, and that can cause urinary urgency. So for that, we would use tolterodine or oxybutynin, which are both good for stress incontinence. Okay, question 10. 31-year-old man presents to your clinic complaining of leg weakness. He said it started in his ankles last week, but is now in his thighs and is making it difficult for him to walk. On physical, legs and ankles are notable for weakness, +1 out of 4 each. Arms and wrists are normal. Sensory perception is perceived both to pain and light touch in both lower extremities. He had no neurologic symptoms last time you saw him, which was last month for what was viral bronchitis. Which of the following is the best next step in the management of this patient? A. Nerve conduction studies. B. Electromyogram. C. Brain MRI. D. Head CT. E. Lumbar puncture. All right, the answer here is E. Lumbar puncture. So this is a patient who's got weakness. It's symmetric weakness, and it is in the ankles, and then now it's in the thighs. This is an ascending symmetrical weakness. And an ascending symmetrical weakness who also has no weakness in his arms and wrist, and he's got no sensory deficits, and he's had a recent infection. What does that spell out? That spells out Guillain-Barré syndrome. And the best initial test for Guillain-Barré syndrome is a lumbar puncture for CSF analysis. So Guillain-Barré syndrome, the history, often the patient has had a recent infection, but don't rely on that because not all patients remember. A lot of times the infection is diarrheal because the most common pathogen associated with Guillain-Barré syndrome is Campylobacter. But sometimes it can be upper respiratory, or it can be a herpes infection or other infection. And sometimes the patients won't remember an infection. So that can be part of the history, but you can't really rely on it. The symptoms. This is what makes Guillain-Barré syndrome stand out. It is an ascending weakness. It starts in the feet, in the ankles, and it goes up to the legs and then to the thighs. It can be described as pain. There may be paresthesias, but none of that is necessary. What makes this unique is that this is an ascending weakness, and it starts in the lower extremities and works its way up. Facial or bulbar or upper extremity symptoms are less common, but that can be an atypical presentation of Guillain-Barré syndrome. What we're most concerned about with Guillain-Barré syndrome is that the symptoms can progress to the diaphragm. The good news about Guillain-Barré syndrome is that it goes away. But the bad news about it is that it can be deadly because it can progress to the diaphragm. And remember, if you have paralysis of the diaphragm, you can't breathe. So any kind of acute weakness or paresthesias isolated to the leg should arouse suspicion of Guillain-Barré syndrome, especially if it's ascending weakness. So this should be ascending symmetrical weakness, starting in the feet and working its way up. And oftentimes after an infection, some kind of an infection. What do we see on physical? We see weakness of the lower extremities and loss of deep tendon reflexes. So this is a lower motor neuron disorder. Routine labs should be normal. Presence of fever or incontinence should alert to alternative diagnosis. And on the suspicion of Guillain-Barré syndrome, as mentioned, the initial diagnostic step is a CSF analysis. What are we looking for? We're looking for the classic CSF presentation of Guillain-Barré syndrome, which you should have ingrained in your mind: elevated protein and no cells. We often see elevated protein in the CSF if, for instance, you have meningitis, but in that case, we would also see cells. Elevated protein but no cells doesn't happen anytime else but Guillain-Barré syndrome. So the best initial diagnostic step is cerebral spinal fluid analysis, which shows elevated protein and no cells. Now, the most accurate test to diagnose Guillain-Barré syndrome, but not the first test, is going to be an electromyogram. Question 11. So now this is the same patient. Lumbar puncture is performed and the CSF is notable for elevated protein. No cells are present. Which of the following is the best next step in management? A. Admission to the hospital. B. Prednisone. C. Physical therapy. D. Oral vancomycin and ceftriaxone. Or E. Intrathecal antibiotics, IV vancomycin and ceftriaxone. And the answer here is A. Admission to the hospital. So steroids don't play a role in Guillain-Barré syndrome. Physical therapy may be useful after his Guillain-Barré syndrome has gone away to help him regain some strength. And then oral vancomycin and ceftriaxone would be useful for, these antibiotics would be useful in the event that he was diagnosed with acute meningitis. These are good empiric antibiotics for acute meningitis. But none of those are the case. He has Guillain-Barré syndrome. He needs to be admitted to the hospital because the most important thing for Guillain-Barré syndrome is observation. It's to make sure that his Guillain-Barré syndrome does not progress to the diaphragm. So this is just a little cartoon. This isn't mine. This is from the, looks like, Nursing Education Consultants. But these are some of the risk factors and some of the symptoms of Guillain-Barré. Okay, diagnosis, as mentioned, is cerebral spinal fluid analysis. Once you've made the diagnosis, the patient should be admitted to the hospital for observation and for treatment. Now, what can we do for treatment? We can use plasma exchange or IVIG. We don't have to, but that's what we do if it's bad enough. So generally, we tend to observe them, and if the Guillain-Barré has progressed enough to where it's problematic or to where it's affecting the diaphragm, then we can do plasma exchange or IVIG. But for the most part, we're just observing them. So now this is the same patient. We've admitted him to the hospital. Which of the following is the most important parameter to measure frequently in order to best manage this patient? So I already told you, we've admitted him to the hospital to observe him. What are we observing? A, body temperature. B, pulse oximetry. C, respiration rate. D, pulmonary function test. Or E, cardiac rhythm. Alright, and the answer to this question is D, pulmonary function test. So we are concerned about his vital capacity. This is what will tell us how paralyzed, how weak his diaphragm is. So we monitor vital capacity. We monitor it daily, if not usually more than daily. Usually it'll be monitored 2, 3, 4, 5 times a day. And if the vital capacity goes below 15 milligrams per kilogram, then this represents diaphragmatic involvement and the patient will need to be intubated. So this is the genesis of why the patient needed to be admitted to the hospital in the first place, because we need to monitor his vital capacity until the Guillain-Barré syndrome goes away, which it always does, but we have to monitor him in the meantime to make sure it's not going to his diaphragm. And if or when it does, then we will transfer him to the ICU and intubate him, probably sedate him as well.